Welcome to Because We Love You. We have a treat today. This is my mentor and who I work with. So if you've been watching the podcast, you know that I love medicine and I love treating people and making people better. And this is one of the reasons why. So this is Dr. Catherine Metheney. And we've worked together for 13 years now, almost. It'll be like 13 years in December. I like to joke the first time she met me, I think she was very unsure of me. And she was like, I did not hire you. But I grew on her, and now we've worked together for this long, and we've had a great relationship. She had her undergrad at Chapel Hill, and she had her medical doctorate at Wake Forest with me, but not with me. Yeah. I was physician assistant, and she was MD. So I thought it would be a treat for us to discuss some of the things that we hear, not just in our clinic, but also like when we're out in the world, like things come up and we're like, yeah, and I hear that every day with patients, and like we want to have patients and you guys be in the know. So I start this episode because it was very interesting. We were at my kids' basketball game the other day, and I leaned over on my husband, and he said, "Wow, you feel so hot." And I knew I'm used to being hot. I've been hot for years. He just didn't notice it. But I was on fire that day, and he was like, "Are you always like this?" And I was like, well, recently, once I've gotten into I'm 40 now. I just have to admit it. I'm in my 40s, and I just get hot sometimes. And so that made me think, you know what? I probably am perimenopausal. Mm-hmm. And how many times do we have perimenopausal women come in here and they were like, what's wrong with me? What can I do? What do I do? So I wanted to just get, what are your perspective? What is perimenopause?
Gotcha. And every woman's going to go through this. So, and the timing can be somewhat variable just because genetics can, of course, play a role in this. Things, prior treatments, cancer treatments, things like that, certain medications, surgeries, of course. But for the average woman in the United States, menopause, which is when you quit having a period and hormones are just done and it's game on, is right around 51. So perimenopause on average starts about 8 to 10 years before that. So for some women, it's more mid 40s. For some women, it's early 40s. For some women, it can be even in their late 30s. Mm-hmm. And so what happens is you start to experience some of those symptoms, usually in a more mild version than what typically happens once you're completely menopausal, which is usually when you haven't had a period for a full year. But those symptoms can range, and the most common is hot flashes. So that's like 80% of women will experience hot flashes, and they can be mild, where it's just the feeling of being hot, to severe, where literally your hair's wet, your clothes are drenched, and so they can kind of
where you have steam coming off your head.
You can
see women in the winter, and you're like, "Oh, you're having a hot flash."
Yes. So again, it can vary in intensity, frequency. And then just how disruptive it is to life, to be honest. For some women, it can affect sleep quality. Start affecting sleep quality, then can affect things like mood. Sometimes just the feeling of hot flashes can create sensations of anxiety and increased heart rate, which just that alone can be a little uncomfortable and a little scary, if you're not quite sure what it is or what's going on. But then other symptoms that can come along with that, including some of those mood changes, which can happen. You can have symptoms of vaginal dryness, more discomfort with urination, things like UTIs, and some of those changes, again, can be more mild or they can be much more intense.
So when we have these patients, when we have these symptoms, we do have to note that this still is a natural process, that this is not a disease that we have. Right. This is how it was meant to be. Unfortunately, some women, you say not at 35. This was not meant to be the at 35. But some women is much later. I had a lady today, she was like 57 and had just gone through menopause. And she was like, and I still feel pretty good. I'm like, because you probably still have some of those feel good hormones. Yeah. But I also we see a lot of people struggling with weight
Yes.
and perimenopause. And I think
Yes.
that's one of the things that they're like, my hormones must be off. So when you have that type of patient, they come in here, my hormones must be off. What should people be thinking? Should they run to us or what should they be thinking?
So I think first of all is just to recognize that some of those symptoms are typical with menopause. And I think sort of if you realize that, then it's really putting your focus on what is the self-management? What are the things you can do on your own to really help mitigate those symptoms that isn't a pill or something else? And so, and honestly, for a lot of women, when they get into their 40s, which again is when most women are starting that transition, there's a lot going on. You know, their life is busy, they're full, they might have kids, they're potentially a spouse, they're doing a million things, and there's a lack of probably self-care a lot in women who are in their 40s. And I think that leads down that path of weight gain, sleep disruption, you know, even part of the mood shift. And so a lot of the treatments that have been shown to be really helpful for some of these symptoms really are self-management. It's working on getting a good night's sleep.
Huge.
It's cutting out things like caffeine, which can also affect sleep, right? It's finding that time to exercise, shooting for that 120 minutes a week. Moderate intensity. And it can be broken up into little segments throughout the week. It's putting healthy things in your body, getting away from those highly processed foods and just running out and grabbing something because you're also grabbing something for the kids, right? And then you're like, well, I might as well just eat it too, or I'm not even going to be able to eat. I mean, that's just real life. But I think that's a big piece of it. And a lot of it is just putting that focus back on caring for yourself and doing those things that, put you in a healthy place. We do know for a fact that women that carry a little bit more weight in the middle increases the risk for developing hot flashes. And so again, just continuing to put that focus back on yourself for care. And then there are times where things are more intense, they are more severe. And that's when I do think it is appropriate to come in and have a conversation with your doctor. Is medication where you're at? A lot of times we can tell a lot what's going on just by the symptoms you're having. Honestly, more so than just looking at your numbers on a piece of paper. What you're experiencing really tells us more if you're perimenopausal or if you're now postmenopausal, more so than the numbers. The numbers can fluctuate so wildly during perimenopause, so it really doesn't always help us know what to do for somebody.
Yeah, so I get a lot of pushback sometimes when they're like, I want my hormones checked. I want my hormones checked. And even we'll sometimes hear, I don't know if you've heard this, is they feel almost dismissed sometimes by GYN and their gynecologists. They're like, they don't want to check them. And then they come to us and they're like, well, you. Yeah. And so what, when is it appropriate to check hormones and what do they tell us?
So I think it's reasonable if somebody is definitely experiencing symptoms very prematurely. I mean, if you're in your early to mid 30s, that is technically premature. And so I think that's a reasonable time to start checking hormones. And I would say definitely if just something is really unusual, if there's signs of excess androgen and hair growth and things that just aren't quite fitting with your typical menopause picture. If there are symptoms that are more thyroid issues, and that might be another reason to check it. But again, it doesn't really guide care a lot. It doesn't really a lot of times change the outcome and when we're just checking it for typical perimenopause and menopausal symptoms.
So say someone though we did check and their estrogen was very low and they are showing signs that they are in perimenopause, maybe even in menopause, and they bring up hormones and a lot of people do feel good with hormones. Yeah. Tell me your thoughts on hormone replacement therapy and perimenopause/menopause.
Yeah. So there is a role for it, absolutely. It can be a good treatment option for some people, again, in conversation with your doctor, because there are a lot of pros and cons. Typically, if you're going to start hormone replacement, it needs to be before the age of 60, and it needs to be within 10 years of going into menopause. And occasionally, I mean, I know it sounds weird, but occasionally I do have somebody that comes in and they're 15 years out and they're having hot flashes and they want to go on hormones. And I'm like, no. Because there's some significant increased risks of doing that, cardiovascular cardiovascular mostly risks. So if patients really are experiencing moderate to severe symptoms, like they really are significantly disrupting quality of life, and have consistently tried some of those other self-care things, right? Like really working on sleep and exercise. There's actually really amazing data out there about cognitive behavioral therapy for hot flashes. There are tons of studies out there showing it does actually work. And part of that can just be learning things like breathing techniques, calming techniques, cooling imagery. I know that sounds really weird, like think about really cold things. But it really can be helpful. And again, multitude of studies to show that it actually helps with the frequency and the duration of the hot flashes and the intensity of the sensations. But again, sorry. But if you really have tried some of those things, so that's where, again, having that conversation, try some of those things first, see if that mitigates the symptoms again. So they're more, maybe they are feeling more mild to you now, in which case maybe I don't want to put extra things in my body. And part of this is the natural process that your body is going to go through. But again, if those symptoms really are disruptive to life quality, then that can be a discussion with your provider about if you're a good candidate for it. There are some, big no's, history of breast cancer, blood clots, things like that, because it will increase the risk. But if they are used safely and effectively, they do have to be, monitored carefully. If you give somebody hormones, the hormones themselves can cause some symptoms that you might not want. And so, so keeping that in mind, that every medicine, anything that you put in your body, there are pros and cons. It's not always the magic wonder pill that you want it to be. They can cause breast tenderness, for example. For some women, that's a deal breaker, and they come back and go, I don't think I want to take this anymore. I think I'll just deal with my hot flashes. So...
And there are some new things on the market that have been really effective for hot flashes. Yes. I think you've probably prescribed Veoza. That's the brand name. And it's it's a non-hormonal way. So talk a little bit about what are your favorite non-hormonal options to mitigate symptoms of the perimenopause, menopausal women.
Gotcha. So I think that's kind of... and absolutely, there's some fabulous options out there that are non-hormonal. So especially for women where it's contraindicated, or maybe they've got family history of breast cancer and they're just like, ooh, I'd rather stay away from something that might increase my personal risk. And so I think it kind of does depend a little bit on what you're focusing on. For hot flashes in particular, there are a newer agent on the market that you just mentioned, the Veoza. That's really great for women who are more perimenopausal. That is a great drug. There are SSRIs and SNRIs. Those are typically antidepressants, but we do use them in low doses. They have been studied particularly for hot flashes. So that can be really helpful, again, just in really low doses. Gabapentin, believe it or not, we use it a lot for things like nerve pain, but that has also been shown to be helpful. And then also if it's more the vaginal dryness and urinary type symptoms, just a little bit of topical estrogen can be really helpful. And there can be some sexual dysfunction that comes with dryness and things like that. And so actually topical estrogen can be really amazing. And there's just a tiny amount that actually goes systemic, so it doesn't carry a lot of the same risks that oral estrogens do. So...
Yeah. Yes, there are. So definitely have a discussion. So I think it is important. If you are having these symptoms, you can always mention it to your primary care physician or your gynecologist, but to know that there are a lot of things that you need to do. And we've experienced this because we are both women that are now going into this. And so I want to get a little bit personal. I'll start with my personal journey is like, I've really kind of jumped into strength training because I know that is really powerful, not just in mitigating my perimenopausal symptoms, but also knowing that is also going to help me in my later years where osteoporosis, low bone density. I want to build my muscle mass now. So that has been kind of like my thing. I'm like, I want to focus on my body, getting better balance. And there was a study that came out, and Harvard's actually doing another study. I looked at it before I came in here, and it's wanting people to come in who aren't doing strength training, and they are monitoring them to see all of the benefits of that in the perimenopausal woman. So I think that that's really cool. So what are some things that you're doing to help with any of your symptoms?
So for me, one is just the general exercise. And
hot yoga. You've talked to me about hot yoga.
I've done hot yoga.
She likes
for
to
a little while.
She thinks if she sweats enough on purpose that she won't even notice the sweating that's not on purpose.
Right. But just kind of like what I preach to my patients, like get it in when you can. Like, if your kid is at practice, like walk around the parking lot, get your heart rate up, leave your sneakers in the back of your car. Like, if you've got, you're waiting for pickup duty, if you're able to get out of your vehicle, just getting really creative, or if it is just a walk after dinner, I've got some dumbbell weights underneath the edge of my bed. That's really weird. But, when I get a few minutes, maybe before bedtime, I'm not trying to do like a big workout because I don't want to not be able to sleep. Because sometimes if you work out right before bedtime, it can actually affect sleep quality. But, I'll just do some upper body, stuff. And so just trying to keep going and do it when you can. I think that's the biggest thing. I have honestly, and this is hard for me to say, I've been really trying hard to cut back on my caffeine. And part of that was I actually went to 3 hours of sleep lectures back in the spring, and I had heard this before about even caffeine in the morning can actually affect your sleep quality. So after I actually saw the science behind it, I've taken this to heart. So I'm really working on it.
And that's a hard one.
But that can also, again, help reduce things like hot flashes, avoiding hot beverages and caffeine, anything that dilates the blood vessels, right? So that can be helpful. And just trying to move into things gracefully, and a little denial is always good. My husband the other day was like, I think you're getting hot at night when you sleep. No, I'm not. I still sleep under 3 blankets. I promise you, every night. I'm not kicking them off in the middle of the night.
I'm so looking forward to winter because I don't even like to turn the heat on anymore. And my husband is it was like 65 degrees on the average in our house. I'm like, no, we're saving money, honey. We're saving money and we need to use these blankets. And I felt great. I was like, I love this. This is perfect. But I will tell you, this is a weird one for me. It's those migraine masks.
Oh, yeah.
My husband recently got me one for just if I get a headache. That really helps. But man, it cools your whole body. Like if you slide that whole thing out and it's out of the freezer, you are just going to, it just feels like heaven on earth just to lay there butt naked with your eye mask on. And it's like everything gets better. And the kids kind of know, like, if you've got something on your head that maybe you don't want to be bothered. So I feel like they just like, I think mom needs a minute. So that's a good one. In closing, I just wanted to touch base too. Something you said, so impactful, and you've mentioned it a lot, but sleep. I tell patients all the time, sleep is the domino effect to your life. Like if that one thing falls off, then everything else starts to trickle down. You are a little bit more like mean or groggy, and then you go for the caffeine, and then you're like, oh, I need something to make me feel better. And then you eat foods that start to build and produce insulin resistance. And then before you know it, you're diabetic and you're hypertensive, and it was all tracked back to sleep. So if there is anything that we would leave with you, work on your sleep. Get it right. Focus on it. There are a lot of even natural things that you can do now. Magnesium, ashwagandha. I don't know if you have melatonin. And if you have any tricks.
Valerian root. Again, if you want to try something more herbal. Absolutely.
So try all the things. And then there are even medications that if it gets to that point, we can give you medications that can help you with sleep. But if you take one medication and you don't have to take all the others, then it's worth it. So Thank you so much, Dr. Metheney. This was great. We do have, stay tuned next week because we are going to be talking about the weight loss, which everybody wants to lose a little bit of weight. So, and you've probably heard of the drug we're going to talk about. So stay tuned. We do this because we love you.